Welcome to the American Hospital Association special podcast series, Just Lead, a look at how hospitals and health systems that have been recognized with AHA awards for innovation, collaboration, and health equity are transforming healthcare to better serve their communities. So what does this mean for patients? I'm Tom Hedderly with AHA Communications. Today we are joined by a finalist of AHA's 2022 Quest for Quality Prize, Ochsner Medical Center in New Orleans. Hospitals and health systems are encouraged to apply for the 2023 Quest for Quality Prize by October 21st. Learn more at aha.org/questforquality. Now let's join their conversation.
Well, good morning. My name is Marie Clary Fishman. I'm the Vice President of Clinical Quality at the American Hospital Association. I'm really honored to be meeting with you both today with Dr. Schubert and Dr. Truxillo from Ochsner Medical Center. We're really excited and happy to have you involved with the Quest for Quality Award and being here this morning to talk to us about what some of the things that you're doing and the really important work. So thank you for joining me. Let's start out this morning. I'd like to hear a little bit about a project or an improvement process that you've been working on that's really, really important to you, that really has brought things to life with the medical center.
Well, I can take that one. That was a project that I actually got started with quality improvement with. We started a number of years ago revolving around inpatient deterioration on our floors. And to give y'all a little bit of background and history of how we got started with this process, as our medical center continued to grow and be the referral center, the tertiary quaternary referral center for our Ochsner Health system, we started to see an increasing case mix and patient acuity on the floors, which led to an increased number of rapid responses and floor codes. And at that time, we looked at that and noticed that trend and decided that we had to make some changes to the way our processes worked. And using well-established IHI principles of process improvement, we went through multiple PDSA cycles and really used a multifaceted approach to bring down the number of cardiac arrests on our floors. Over a 2-year period, the total percentage decrease was well over 70%. And we really used every tool in the toolbox. One of the more innovative action items was implementing a deterioration alert for the hospital based upon patient vital signs, data in their medical record, using artificial intelligence to pull and aggregate all that data and to identify our rapid response teams of a patient who is at risk of needing an ICU transfer within the next 3 to 4 hours. So that put our clinicians at the bedside in time to make interventions to help prevent deterioration on that patient. We also changed the daily work of our nurses and physicians. When we began the project, the rapid response team was a reactive team. We waited for that alert to go off and then we responded. And what we saw was our bedside nurses had very good insight on when a patient was declining. And by implementing and changing that team from a reactive team to a proactive team that actually went out, visited each floor, each unit, spoke with the nurses, asked the questions, what patient on your unit is going to be most at risk of deteriorating today, or who are you concerned of? That proactive approach helped drive a further decline on top of the other improvements that we had already made.
So is it the team that actually rounds? Who are the members of the teams that kind of go around in that proactive way?
So the proactive team, we grew the team as the need changed. So we started with a pilot doing one nurse just for the day shift to see how it worked. Very successful. Moved it to one nurse 24/7. And once the nursing staff knew that they had this resource to call on, they started using it more. They started noticing getting the help. And so we added 2 nurses and a respiratory therapist. So at this time, we have 2 rapid response nurses 24/7, proactive rounding, as well as a respiratory therapist.
That's great. That's really, I like that idea. That's innovative. You mentioned AI and the role that AI played a role in this. Can you describe that a little bit more?
Yeah, the AI is a great way to take the data that we already have in our medical record, making that transition of having the EMR work for us and provide us with information to make a good clinical decision. It's not going to give you a diagnosis. It's not going to tell you what's wrong with the patient, but it's really that second opinion almost working in the background to say, hey, take another look at this patient. Something's not right. This patient, based upon, and the way AI works is you build models and you train the algorithm based upon the data from your current organization. And so based upon prior experience in this organization, this patient looks like they're going to be at risk of needing a transfer.
That's really interesting. And do the patient's vitals feed into the system as well? So in a proactive way, I guess, versus past, but is that an auto feed or how is that working?
Yes, that's a great question. As an anesthesiologist, I'm fond of saying vital signs are vital. And so it's one of the key indicators we have. And a number of our units, we use remote monitoring, real-time remote monitoring, that's constantly being fed into the EMR. And then that data in real time is being fed into the algorithm. And so we'll see those alerts go off often well before anybody else realizes that something's going on with that patient because you're getting that real-time vital sign data.
That's amazing. Have you done any sort of post-retrospective or kind of a longitudinal review of the occurrences that have given you any insight into the changes you've made in the processes going forward?
So we review weekly review sessions. We review every event. We look and have identified patterns and trends in our organization of what type of patients are going to be at risk of deterioration. We know that over the course of time, aspiration risk is a big risk in the organization. So what steps can we take to get upstream of that and to help minimize those risks for patients? But that rapid cycle review of looking at all these, feeding the information back to the units, making sure the nurses are aware of it, making sure the clinicians are aware of it, all those things really work together in synergy to help make it a safer hospital.
That's really great. And the last question I have around that is the role of patients and families. From my own personal experience as a clinician, at times patients or family members notice a change in a patient before the clinician might. You know what that person is like. And does this rapid response and this early deterioration process, how does the patient's family fit in if they happen to be there or if they're part of processes? Do you explain this to them? How does that work?
A lot of this changed with COVID because families were not around as much in the hospital, but now that we're resuming normal operations, patients' families are back in the room, and they're often the first, as you mentioned, the first people to realize something's just not right, and they may notify a patient care tech, they may notify the nurse, they may notify the nutrition staff. All those individuals know to call the rapid response team to get help, and we have a one call that's all number, so everybody in the hospital knows if you need to get help rapidly, this is the number to call. And like you said, that insight and really tapping into that. The AI is a way of making that intuition into a digital form, but the personal form is still very, very sensitive, whether it comes from the family, your clinical staff. So combining those two together truly helps make it a safer system.
I love that balance. I think that's so important. And on the other end of things, I would imagine that doing something like that would involve leadership in the organization, the board support, the medical staff leadership, nursing leadership, all of those folks. So, Dr. Schubert, can you talk a little bit about the role that the board and leadership plays at Ochsner in getting these kinds of initiatives and this kind of amazing change implemented?
Yeah, absolutely. Our board is extremely involved in monitoring quality and safety at all of our hospitals, but specifically our medical center. They receive, through their subcommittee on quality, monthly reports on what we call the zero harm metrics, so those things that really are conditions that are harm events that we believe could be avoided completely, as well as mortality. And so through that surveillance and physician leadership at that level, we have a large number of physicians on our board. That is a community board, but we have a good representation there. And they often can spot trends when they look at the data. And this effort that Dr. Truxillo describes was in part the outgrowth of concern on the board with risk-adjusted mortality trends. There were other actions that came from the board related to that, but this certainly was one direction that they identified and helped resource and encourage.
That's amazing. That's really impressive. I think that having that board involvement really makes a difference, because as you're trying to pull together all the different folks across an organization, knowing that the board is really supporting and, as you mentioned, maybe financially supporting an initiative like this or an effort that is really important.
Yeah, absolutely. And the related actions that the board helped us with when it came to examining risk-adjusted mortality and the drivers behind that included their attention to the need for more palliative care. And so through the board's advocacy and direction, we were able to substantially strengthen palliative care programs in the hospital, but also in the community. And to the point where now palliative care is a mainstream consideration for all of our patients and is part of leadership discussions continually.
That's really impressive. I mean, I think that there's been so much challenge to the public trust with COVID and all of the kinds of things that have gone on over the past 2.5 years. So let me ask this question. Have you messaged some of these kinds of activities to the community? We're so embedded in the communities that our hospitals and health systems live in. Have you worked with the communities, sort of shared some of this information with the folks in the community to really work on that connection and that public trust?
Absolutely. Perhaps when looking at our relationship with our community and the impact, we see it as a broad spectrum. Certainly, access to healthcare is a huge piece, and so whether it's through our emergency department or our urgent care clinics or even our specialty clinics, and in particular, our medical center is the referral source, referral destination for services that cannot be easily obtained elsewhere in the state, such as solid organ transplantation, advanced cardiac assist devices, and the services, for example, that are available through a comprehensive stroke center and the 50 or so hospitals that depend on us for sending their patients. So through the activities of outreach programs with hospitals and their communities, through our relationships with our governor and the city councils and mayors, we have been able to communicate our commitment to the community in a major way. One example is what we feel is perhaps the most inspiring initiative that in my career, at least, I've been associated with, and that is what we call the Healthy State Initiative. And so knowing that Louisiana as a state, along with Mississippi and some neighboring states, are always seemingly at the very bottom of the health ratings list, we have committed, in collaboration with our state leadership, the governor, 2 of the major city mayors, and also leaders of local institutions of higher learning, to a 10-year initiative to improve the state's health equity, and health outcomes with a large investment and a commitment to move from our last place in the state health rankings to at least 10 points better than that, to about 40.
Yeah,
We call
great.
that the 40 by 30 initiative. So 2030 is the idea. And we think about the communication with and interaction with and influence on the community also in terms of health population management. So we have a group which is supported by our medical center that looks at health outcomes and prevention processes such as health screenings for cancer, health screenings for diabetes and retinopathy, and the control of these chronic conditions which affect our disparate populations to a greater degree than perhaps in other areas, in some other areas of the country. We measure these outcomes, we publish these outcomes, and recently, during the COVID intense period, also have been able to strengthen our relationships with our communities even further through our just heroic vaccination and testing programs. We, by now, must have vaccinated nearly 1 million folks, certainly in our greater metropolitan area, but also surrounding counties. And this involved extremely good collaboration with state health authorities, county health authorities, the Saints organization and other athletic organizations, our international airport authority, and many malls in the area to really provide this type of mass vaccination program. One example was we essentially were given access to the parking lot of a large athletic field and had drive-through vaccination efforts with up to 10 lanes of drive-through capabilities. And just the joy you could see in folks' faces and the relief when they were able to get the vaccination was just so enlightening and inspirational. We also worked with communities of faith, and especially in the New Orleans East area, which is one of the areas of greatest health inequity and very much dependent on building trust with the community. And we just heard this morning at one of the HA sessions that trust in our health systems is only barely greater than 60% of the population trust in us. And so we really had to work hard to gain the trust, especially of our Black population, which has been affected by historical precedent. And so we had built this relationship with this one large Baptist congregation, and our physicians actually went to the site, met with members, and especially with leaders, with church leaders, elders, and gave them the confidence to speak to their congregation so that they would have their congregation be able to take advantage of these vaccinations. Another community effort and communication and interaction that we highly treasure is our work with the schools. So, for example, we knew from our community health needs assessment for several years in a row that health education was one of the areas of extreme need. So we have partnered for a long time with school systems, but the COVID period presented an opportunity to deepen those relationships. And so, for example, we worked with school boards and school systems. Overall, I think it's been more than 25 individual schools and 5 large health systems to allow them to help their students return to the classroom. And this ended up affecting over 120,000 student lives. We ended up vaccinating over 10,000 teachers. And to this date, we have school clinics with school nurses, with social workers, athletic trainers, and are able to work with individual schools also. The Discovery School system is a very good partner for us. We actually donated a whole building and educational equipment, and this helps us also communicate the need for a healthcare workforce.
Right, yes. I think that one of the things that I've noticed during all of COVID is that we all think of our individual needs. But as individuals, we're all part of a community. And so that balance between myself as an individual and myself as part of a community seems to be something that many have struggled with during COVID. And Ochsner seems to be doing a really good job with trying to give people answers to that question. Here are the issues for you as an individual, but now we go to your community and we address it as part of the community. And I think that's a real key in managing this, and I think it's a real key to recovering the public trust issue as well, because you address both pieces, and I see that. Dr. Truxillo, anything that you would like to contribute about the community and Ochsner's partnership with communities?
Dr. Schubert mentioned a lot of great projects going on. I think to loop back also to the digital health, like how do we make care more convenient, more affordable? So we've invested heavily in our digital health services to actually bring care and access through digital medicine, digital health programs to individuals, in addition to the community health centers and all the other efforts that we've put into working with the community.
Yeah, that's a great point, especially when it became very difficult for our community members to visit us because of the state lockdowns and the general fear in the community. We had an intense outreach opportunity through telemedicine and digital health. And in those early times, our telemedicine visits actually increased by 500 to 1,000-fold from previous levels, and still continuing now, where many of our patients prefer this level of engagement.
Yeah. Yeah, it is a transition even with how we get work done. So much has been either through Teams or Zoom but all of this work, which is really amazing, and the focus that you have from the board through to the bedside and improving the quality of care that you've provided is really, really impressive, and certainly obvious as to why you're working with the Quest for Quality and the award. Can you just tell me a little bit about the team members, the staff? They've been through a lot. It's really been a trying time for folks, but I'm just wondering, I'm imagining that the kind of work you've done, especially with the inpatient deterioration, the alerts, have you seen the staff feel a little bit better about the support, and with putting those resources to the bedside, has that helped folks feel a little more supported and reinforce that?
Absolutely. Anything today that we can do to help support our staff, make sure that they feel like they're able to deliver the highest, best quality care that they can deliver is appreciated. It's really helped just keep individuals engaged with work because they know that our organization is going to do what it takes. And a lot of that comes out of COVID, just the focus and the speed at which we were able to make things happen. We were able to add 3 floors of ICUs in about 90 days to care for the community because there was a community need and nobody else in the state could do it. So the bedside providers know that the organization is going to do what it can to help keep our patients safe.
Yeah, it's a real challenge for our teams and patient-facing healthcare team members, and especially nursing went through an immense amount of challenge and trauma. And so these inspiring projects and activities definitely help us reconnect to our purpose and allow folks to realize that the organization is behind our teams. Even though we're still short-staffed, we're still having to struggle with temporary personnel and disruptions that go along with that. But programs such as what Dr. Truxillo provided and other programs which we have, like our virtual nursing program and another program that we call the unit-based APP program, are designed to bring more help to the bedside and to the personnel who are already stressed. For example, the unit-based APP program, which is essentially having a nurse practitioner or PA resident on a floor, a 30 to 40 bed floor, so that patient or family situations can be addressed quickly. If there's help needed, there's just a person down the hallway as opposed to 15 pages away. So with that, it's been estimated by our nursing floor leaders that possibly up to between 3 and 6 hours of nursing time could be saved by having a member of the medical staff directly resident on the floor and able to help with service recovery, difficult family questions, and bringing comfort and necessary care to the patient's bedside quickly.
Well, congratulations on your participation in your award with the Quest for Quality. I certainly, in our limited conversation, see great examples of, working through leadership and partnerships, working with your community, focusing on equity, using data to make your decisions, really all of the threads that you see in quality improvement, and a great asset to the community, and really appreciate your participation. Thank you both.